I'm working really hard to stay on schedule today. So I'm gonna transition to Dr. Jeff Gold, who is a family physician. We share the same uh, undergrad, or not undergrad, but medical school alma mater. And he is a direct primary care physician, which you guys are going to learn quite a bit more about. We're going to shift gears a little bit because we are looking at more of the general take medicine back aspect today, as well as empowering physicians themselves, because we did a little bit of a poll and saw that non-scientific poll, but how many people are working at their envision jobs or team health or whatever because they feel like they can't escape corporate benefits. We're staying at work because in these abuses, and not going part-time because we just need the benefits, the BUCA plans that we all hate, right? We're all sitting here being like, the United is terrible. We don't want to, accept them in the ER, but I need my United plan. And I think we have to start thinking outside of the box and getting out of that mindset a little bit, and stop buying the lie that they bought into. I'm not necessarily talking about broad reform, like any Medicare for all things. I'm not talking about that here. But when we get to that point in Congress, I want to have rational, authentic voices that can do that. So today's more, at this point, more about what can we do for our own families, and we have to understand this stuff first in order for our patients to understand it. And I think Dr. Gold does a great job of that. He's also my family's physician. A very brief interlude here. When I was first learning about direct primary care, I was watching lots of videos in a conference similar to this. I think it was Nuts and Bolts, I believe, DPC, one of those. And I was watching all kinds of videos of how do you start this. And I saw Dr. Gold take off his shirt.
No one wants to see that.
Not this time. Well, we can. This conversation started out with talks about whores and hookers, so I think we can keep the theme.
I missed that part.
Yeah. So Dr. Gold had a tattoo. Long story short, I stopped. I paused the video and I thought, man, my family would do a lot better with a direct primary care doctor. And I went and I looked on the direct primary care mapper and saw that Dr. Gold was half an hour away from my family, and I said, this is just too much of a coincidence. And so now he's my family's family practitioner. So without further ado, Dr. Gold, give us a background and sort of, I don't know, breaking the mold and what brought you here.
Thanks, Mitch. I've never been introduced with a tattoo discussion before, so there's always a first for everything, I guess. But and thank you for, more importantly, trusting me with your family. They're great, and I really enjoy caring for them. I don't think my story is probably much different than any physician that's working in a patient care setting. For the first 10 years of my career, signing the insurance contract and working for a hospital system, I was married at the time, trying to start a family. I was a good coder and biller. I was fast. I could see 20 to 25 patients a day working for the hospital. I had a lot of Medicare Advantage patients with, the coding game that allowed me to get a nice bonus every year. But, the reality is it worked for a while and it, helped pay my bills. But then I found myself getting angry, trying to code Medicare physicals the right way with, Medicare patients who take an aspirin and a vitamin a day and don't have any chronic medical issues, that I'm sitting there trying to figure out how I'm going to code a Medicare physical so that they don't get billed $450, because many people don't realize that Medicare doesn't cover physicals. They cover some screening tests, but they don't cover a full annual checkup. So what a lot of outpatient docs do in family or internal medicine is they take the chronic diagnoses and make a 99214, 213, 215, so that the patient doesn't get stuck, with a huge bill and just code it as an office visit. And I think the problem with a lot of our system is the patients, and to some degree the physicians, are so disengaged from the transaction that they don't even realize like what is going on behind the scenes and how this works. And and it's really an apolitical issue. We're all patients, we're all, caregivers, and we all have family that we care about. And, we have to start asking ourselves, what type of system and what type of care do we want for ourselves, our kids, and our families? And, I found myself getting aggravated at these, little people for coming in with these lists of picayune things. And the whole reason I got into medicine and primary care in the first place was taking care of my grandmother, who, when I was in high school, got dementia early at 62. And I was like, is this the type of, I went home one night and I was like, is this the type of reaction that I would want, my parents or my grandmother's doctor to have? And I realized I wasn't mad at the patients. I was mad at a system that gave me 10 minutes with the patient, and not able to take the time to go through those issues that were relative to her and were important to her. And, I started realizing I have two options here. I've never been a puppet. I've never been one to keep my mouth shut. So moving up in administration for the hospital system to make more money was not going to be on the table for me, because I just didn't play the game. So the other option was stop listening to myself complain and actually do something about it. And as we know, most ER docs, primary care docs, are highly risk averse and do not want to leave positions of comfort. And it's a little bit of a Stockholm syndrome. It's a little bit of a beaten down mentality where, what else can we do? And, I'd heard about concierge medicine around the Boston area. But it never really, and I don't begrudge anybody doing it, patient or doctor, it just never fit with the type of care that, and the type of populations that I like working with. I like a variety of people. And I felt that model where they bill insurance and take a retainer fee was, just above and beyond what most people can do. And I heard about direct primary care through Twitter one night when I was setting it up. And I was like, almost found my messiah. I was like, this is the way this should work for everybody. And if we do it the right way, we can get this accessible to everybody. And especially, the 20% of the population who I think could use this model the most and need this model the most in underserved communities. Obviously, we'd have to have policymakers be willing to work with us in order to make that happen. But, which is a whole nother issue. But I think that, I got an angel investor who is a patient of mine who actually made all his money in the stop loss insurance industry. And he really believed in what I was trying to do. And, I brought it to the hospital system to say, hey, can we pilot this through here so I don't have to pick up and move? And I knew that was going to go over like a fart in church, which it pretty much did. And they wanted nothing to do with it because, you're not taking third-party contracts. So when my patient was like, hey, I want to give you a line of credit and help you do this, I was like, let's do it. And it's been the best move that I've ever made. Obviously, I am in debt, for a while, and I will be for the first time in my life. I was very fortunate that I didn't have college or medical school debts as an only child, and also going, to a state medical school at UMass. But I basically, really feel that the fact that we pay to take a stitch out of a patient or a splinter out of a patient's finger in the same way that we pay for open heart surgery is just asinine. It makes no sense. And unfortunately, what the government and insurance policy, advertising, marketing has done over decades is they've made people, including physicians, believe that everything we do in healthcare is super expensive. So if you don't use insurance to pay for it, you're going to go broke. And the corollary of it is they also tell people that if you don't have insurance, you're going to be dead on the street, that you can't get good, affordable care, and they're both bullshit. So the reality is we have made primary care expensive by insuring it with an I. What we need to do is we need to insure it with an E that everybody has access to this type of primary care, which is looking back in history at where primary care used to be, which is in the community, relationships with patients, knowing their family, knowing their personality, knowing what their goals, dreams, and desires are, and being able to take care of them, but bringing in the fact that we have all this technology now where we can take care of them outside the office and do it the right way. And, I think with everything going on in the world, or especially in this country, you see all the articles, blah, 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 that COVID has killed, primary care. No, what COVID did is it took a really big spotlight and it put it on every inequity and every fallacy that we have in our primary care system. And I include mental health in that, because the reality is most primary care docs are really doing the mental health now because the access to psychology and psychiatry is so poor. It was bad before COVID. Now it's like, just forget Itsville. So a lot of that is being taken on by us too. And, to steal this from a friend and colleague of mine in Lawrence, Kansas, Ryan Newhoffel, he wrote this really great thought exercise on his Facebook business page. He's also a DPC doc. And he basically asked people, if I gave you two piles, if I gave you $100 and I said, I want you to put it away in two different piles, one for primary care and mental health and the other for specialty and hospital care, how would you do it? And there's no right or wrong answer, but universally, I have never had anyone say less than $20 towards primary care and mental health. Even if they're going through cancer treatment, even horrible stuff, they say at least give 20 cents on the dollar to primary care and mental health. Now, the data point is when you look at the public and private payers in the United States of America, they do it at 7%. So when you look at all the mistakes that happen, all the ER docs that are like, why am I seeing this patient again in the ER when they could have been seen as an outpatient in their office? It's because when you're seeing 25 people a day, because you're valued at 7 cents on the dollar, that's when mistakes happen. That's when miscommunication happens. That's when misunderstandings happen. And there's a lot of really good docs out there that are just working in a very broken system, and they can't practice the way that they want and the way that they were trained to. So my choice was either shut my mouth and stop bitching about it and just accept my lot in life, that this is what I picked and this is what I chose and the system is the way it is, or get the hell out and rebuild something that actually makes sense and works for people. We operate off a flat monthly fee. Everybody does it differently, but it usually averages out to about $80 a month, and for all-inclusive primary care. I always use like kind of a Netflix Costco analogy, that it's like Netflix membership, but by being a member, you're also getting access to what things actually cost, whether it's lab work, medication, imaging. This is the stuff that concierge doesn't do. They just bill insurance for everything. Well, that's the problem, is we've used insurance as a form of payment rather than actual insurance. If we used insurance the right way in healthcare, not only would the cost of care come down, but the cost of insurance would also come down. If you ever ask anybody, what do you consider good health and car insurance? They say, oh, I pay a couple $100 a month or whatever for a policy. I have a little deductible, but God forbid, if a tree falls through my car, I'm in an accident, I have coverage. Go ask them what good health insurance is. It pays for everything. How is that good insurance? The problem is in healthcare, they can't go and easily shop for how much does this MRI cost? How much are these labs going to cost? I mean, they can go one block and the price can go from $5 to $300 for a lab test. We need physicians in primary care to be that guide. Concierge, the name's gotten a bad rap because of the price point, associated with it. But the reality is, as a primary care doctor, that's my job. I'm supposed to guide people to the places that, if it's something out of my ability to care for, out of my skill set, or I they want a second opinion. We're supposed to be able to guide them to the best quality, lowest cost place. And we have the only service industry in the country where the provider and the consumer of the service at the time of service have no freaking idea what anything costs. And we wonder why we're so screwed up here. So people say, and I think this is a big issue with the transparency movement that I don't like, is we keep talking hospitals need to post prices and blah, blah, blah. I totally agree, right? But the reality is, if someone's having a hemorrhage into their brain or having a heart attack or bleeding into their abdomen, no one gives a damn what anything costs. You just want to get care and you want to be taken care of, right? Where we need the transparency is everything that's done before you put your foot in that hospital door. There should be an open quality and cost market for everything that is done elective and outside of a hospital setting, whether it's a surgery, an imaging, a specialty visit, whatever it is, people should know what the hell it costs ahead of time. The other stuff you can do in the back end. You can look, once you hopefully recover from your brain bleed and get out of the hospital, then you can look and should have access to all the negotiated pricing and how the insurance worked and blah, blah, blah. But really, who cares about costs when you're having a heart attack? People just want to get taken care of. So, I'm a firm believer in Occam's razor. When you take a complicated situation, try to find the simplest answer. People want to make healthcare economics into this big, complicated thing. And we've done pretty good at doing that. But what about we actually just simplify it? And, we give poor people a DPC card and cover the rest with public funds, just like we do now with EBT cards. We give people an EBT card and say, okay, you can go buy Coke and you can go buy orange juice and you can go buy, shitty white bread, but we can't get in the middle of we can't get out of the middle of the transaction between you and your doctor. We have to tell you where to go. So maybe treating people like people and giving them some control and having them have an advocate. I know nothing about the stock market. I wouldn't go buy stocks without talking to a financial advisor. We're expecting people to navigate this screwed up system on their own. And that's what primary care should be doing. When you look at the rise of these urgent care clinics, it's not that I begrudge anybody doing it. They saw a huge fractured system with a huge opportunity to make a bundle of dough. People don't always get sick between 8 and 5, right? But this is what people are using for primary care now. If you look at statistics, I think it's about 47% of people between the age of 30 and 55 either don't have a primary care doc, or if they do, they don't even know who it is. But what we do instead is we build the mansion on the water with the indoor swimming pool, the bowling alley, all the brand new furniture and equipment. But then we take the unsexy looking foundation and we use, little sticks and stones to build it. And that's pretty much what we have as a system. We've ignored the foundation. We're spending 7% on the foundation. And I'm not saying we don't need these bells and whistles. And I'm glad that I'm in Boston with these incredible hospitals, right down the street. But that's not where primary care belongs. And, the only way to get out of this mess is patients and doctors working together to rebuild a system from the bottom up, because the top-down approach has not worked. It hasn't worked in 6, 8 decades now. All they do is shuffle the deck chairs on the Titanic, and they expect it to get better. And the rule makers are the problem. You have big pharma, insurance lobby, hospital lobby, working with the government to make sure that their products are sold and doing well, but yet here we are with nurses and other caregivers on the front line, and nobody's really helping us. So you either continue to complain about it or you find a way to help yourself and help each other. And unfortunately, sometimes we're our own worst enemies as physicians. We battle with each other when really we should be getting together to say, hey, we all have the same mission here, which is to take the best care of people in the most affordable way and best quality way that we can. Why is it so hard to work together towards that, regardless of what, your political beliefs are, religious beliefs? It shouldn't matter. And basically, I think everybody should have DPC for all. That's what I look at it. And then a market of private insurance options that people can actually pick and choose from what they need, get it out of employers. Now, I know this is a unicorn. I know it's not going to happen anytime soon, if ever in our lifetime, but get employer benefits out. They shouldn't have anything to do with health insurance benefits at all. And we know where that, comes from back in World War II. And then have a public option that anyone can opt into if they want, so that nobody falls through the cracks. But until we give high quality primary care and mental health to everybody, we will continue to get screwed. And to me, that's the social movement, because there is no other area of life that you see as much inequity and, things just completely being screwed up as healthcare. And, we see it every day. With people's access to care. Having a card in your wallet does not equate to getting care. It's important and people should be covered. We have people sign a waiver. If we have people who come in and say, I'm uninsured, I hate the government, I hate the insurance companies, I don't want insurance, we have them sign a waiver to understand that we work with insurance people that can help them, because I'm not going to take out their brain tumor, for $90 a month. And I want people protected against that kind of stuff. That's what insurance is for. And it should be for, is major, unexpected, expensive stuff. But unfortunately, we've used it, completely wrong. And, we've had a credit card that we've used with a 99.9% finance rate. And now the chicken's coming home to roost because people are on high deductibles. There's cost shifting. And now it's like, oh, my insurance sucks because it doesn't pay for anything. One of the benefits people I work with, best quote I ever heard, today's claim is tomorrow's premium, deductible, or copay or coinsurance. There is no free ride. And, when you look at states like Massachusetts, where I'm in, and you have 40% of your state budget being consumed by Mass Health, which is the Medicaid program here, there's something wrong. But until people want to be innovative and say, hey, why don't we do some pilots where, maybe at Lynn Community Health, we can take 500 patients into a DPC type model where, the state government pays the monthly fee and, looks at claims, looks at downstream costs. What are we doing to keep these people out of the emergency room and out of the hospital, and actually treat them like people, like give them personalized care that we all deserve. So, that's where I'm at. I was told I'm the first independent one in Mass to do this. I was told by pretty much everybody, including my own family, that this would fail, that it wouldn't work in Massachusetts where everybody has insurance. But, it's 5 years later and, I'm profitable, obviously not where I'd like to be, but my hope is to grow a business model that can not only help patients first and foremost, but also help my colleagues get out of the system and do something that they, really have always wanted to do. I know there's all these discussions online about mid-levels and all this stuff, taking over what we do and blah, blah, blah. And I kind of push back a little bit and I say, well, I think we've kind of practiced as primary care docs on the outpatient level. I think we've practiced down to mid-level care. When you have 8 minutes with somebody, you just refer out. You're not doing all the stuff that you learned how to do in training. Now, the thing I love the most about my job, besides being able to take care of people and advocate and do things like this and meeting, people like Mitch that I never would have met if I stayed in the system, is really practicing to the top of my ability and the top of my training. Someone comes in with urinary retention, I can put a Foley catheter in, and do a handheld ultrasound to look at a post-void residual. These are not things that take a lot of specialty training to do, but the downstream effect of taking care of people in a personalized way and also keeping them out of specialist office and out of the hospital, it's really, mind-boggling when you extrapolate the savings that the taxpayers and companies and people could have. We literally have shot ourselves in the foot in a lot of ways. And I always say, I'm a recovering insurance doctor, in recovery. I tell people I would go back and scrub, toilets at a Taco Bell before I ever go back and work in the system, because it just doesn't work. It works for the people that it shouldn't work for, but it doesn't work for the patients, and it doesn't work for the people providing the care. Whether you're a nurse, doctor, therapist, it's just pathetic that it's gotten to this point. And I'm really, truly hoping that with COVID, we've really shined a light on what we need to do to rebuild this from the bottom up and fix it so that, us as physicians, we're used to working hard. You don't go through medical school and residency and not work hard. But what we're sick and tired of doing is working hard at crap that has nothing to do with patient care. Nothing. It's so enjoyable now to, be able to spend an hour with a patient, to do telehealth and take care of people where they are and where they're at. And, have them email me a quick question about, a diet, and what should they eat? What should they not eat? All this crap that's come up, like wellness. We all hear this term wellness programs. And I just kind of chuckle because I'm like, that just used to be good primary care. That's what primary care was taking care of people to keep them healthy and being there when they were sick and needed acute care and chronic disease management and all that stuff. But I think we need to band together, which is what we're trying to do here, so that ER docs can be ER docs and actually take care of emergencies. And then let outpatient docs really do their job the right way so that we don't have people going to the emergency room for UTIs and chronic back pain and, all the stuff that, having been in residency and working in ERs, I'm like, God, again, so that's kind of my story. Obviously I get a little fired up about it, because I think for the amount of work and money we've spent, we deserve better. Our patients deserve better. But if we keep waiting for somebody else to fix it, my prostate will be the size of a bagel by that point.
On that note, Dr. Gold, thank you so much for speaking. You have a wonderful way of putting this in context. And I think we got amazing quotes out of today. So we're giving, I don't know if we beat Natalie Newman, but we're giving her a run for her money. Listen, I really appreciate you taking care of my family, of course. And that's something that I feel like we have lost. Even our own family doesn't have access to good care most of the time. And what Dr. Gold had mentioned about, us practicing down, I mean, that's totally the case, right? I mean, we know in the ER we're getting referrals, and that's why we think primary care doctors are not smart, because we get everybody from their offices. Well, they never talk to their doctor. You always talk to the patient, and they say, "Oh, my doctor told me to come here." I'm like, "What exactly happened?" They're like, "Well, I called and I talked to a nurse." Well, it's a CNA, and they've been told, if they say anything about anything, it seems like their algorithm is so broad that they send patients to the emergency department immediately. I mean, we're doing urinary retention. We're seeing patients with that immediately sent to the ER, right? New onset AFib. completely stable, always ends up in the ER. I think the way that Dr. Gold had put it, they're practicing down. I think of it in a way that it is like homeopathy, right? We're familiar that homeopathy takes a really potent ingredient and then dilutes it to nothing. And I take that as like really smart physicians, really well trained, diluted down to an 8-minute visit is they're diluted down to homeopathic inefficacy. And what's the point of it? I mean, literally all that's doing is creating an additional stop in the healthcare system before somebody gets to somewhere else and another bill for insurance.
The best part about I just want to interrupt Mitch for 1 second, because
absolutely
the best quote was actually from your grandfather. He actually came in for his first visit with me a couple of weeks ago. And when I tell you, I mean, this guy is, like salt of the earth, New Englander, he's like my kind of people. And he came in with Mitch's mom, because she, helps coordinate his like medicine and all that kind of stuff. So she was in the room, and he was like, he said something towards the effect of like, this is the longest he's ever spent with a doctor in like the last 30 years, like that he actually wasn't rushed out. Like, and you could see him actively getting nervous about bringing up things he wanted to talk about. And I was like, dude, just talk, like, just tell me what's going on and like, we'll deal with it. I don't have to schedule you for 3 more appointments, like to deal with this stuff. And it's like, you see that Stockholm syndrome that these poor patients and us have been like stuck in for so long, where it's like, really what they want is just to be listened to and just feel that they're, cared for. And that's really not a hard thing to do, but it is when you have 5 minutes to do it.
Yeah, no, I really appreciate that. And you taking care of my grandfather, because my grandmother actually died a couple of months ago from a ruptured AAA, pretty dramatically. And one of our ER colleagues actually flew her out of Salem Hospital to Mass General. And I talked to the surgeon actually on right after she was on the table. She looks like the DIC, because they actually surgeon had her cross clamped hand on the aorta actually on the table. So my grandfather's been going through quite a transition there. So on that note, I really appreciate it, Dr. Gold. I hope you can stick around. I know you have patients coming up. I love it I have a small direct primary care practice myself, even as an emergency physician, and we're going to get to that later on today about how our value as emergency physicians doesn't drop to zero as soon as we leave some artificial wall confines. Like, we're probably the best to keep patients out of the ER. And when we work really well with family doctors, and when we're kind of like the ultimate generalist, when you put like a family physician, we're both cradle to grave, right? All genders. And with the acute care end and the chronic care end, and you can keep patients out of the ER and then give them the best care. So I think there's a lot that goes to it.